Good afternoon, everyone. In this section, we are going to cover trauma to the head, neck, and spine. So, before we get started talking about all the possible head injuries and neck and spinal injuries, let's just review some of the anatomy and physiology associated with our central nervous system. Our central nervous system consists of our brain and our spinal cord. Our spinal column is made up of 33 vertebrae. In between each vertebrae is a spongy disc. That disc is there to protect the vertebrae from rubbing or bumping into each other. It also cushions the spine during our movement. So our spinal column is made up of 7 cervical vertebrae, 12 thoracic vertebrae, 5 lumbar vertebrae, and the remaining 9 vertebrae are fused into the sacral and coccyx regions. Pay attention to the cervical area. This is our most common injured area of the spine for our patients. Another thing to note is the lumbar region. This is the area most commonly injured to the EMT from poor lifting habits. There are many different types of brain injuries. We'll talk about each one of them. The first bullet point talks about the coup counter coup injury. Basically, what is happening is we have two injuries, two areas of the brain that are injured from one impact. For example, a patient strikes his head on the windshield of a car. His forehead is the point of contact. Because there is movement inside the skull, his brain moves towards the point of impact, causing an injury there, and then his brain will move back towards the back of the skull, slamming into the back of the skull, causing an injury there. So the coup injury is the impact injury area, and the counter coup is the actual area of the brain that is injured when the brain moves back towards the inside of the skull, causing an injury there. So that is coup, counter coup. A traumatic brain injury talks about the following 4 different bullet points. They can be temporary or they can be permanent, otherwise noted as brief or long term. Basically, what's happening is there's a disruption of the normal function of the brain. So let's start with a concussion. A concussion is a brief or temporary brain injury. Although it is significant, symptoms are basically very mild. They include headache, feeling groggy, and loss of memory to the incident that happened. So typically your patient will repeat themselves asking what happened to them. You'll explain to the patient what happened to them, and throughout your patient assessment, the patient again will ask what happened to them. This could be a sign of a concussion. Although it is a brief or temporary brain injury, it is still significant. A contusion is where the brain, again, strikes the inside of the skull from the resulting impact, causing a small collection of blood to that brain tissue that impacted the skull. A laceration is when the actual brain tissue is cut. This can happen because inside the skull there are many sharp edges that in the areas where the different portions of the skull are fused. A hematoma This is a collection of blood within the brain tissue. So going back to the contusion, that's a small amount of blood. As the blood keeps growing and forms into a hematoma, many other things are going to happen to this patient. We classify hematomas as epidural and subdural. So in a subdural hematoma, that's a collection of blood between the brain and the dura mater. The dura is a thin layer of tissue that surrounds the brain. An epidural hematoma is a collection of blood between the dura and the skull. An intracerebral hematoma is where blood collects within the brain. One thing I want you to keep in mind is that we do not want you to diagnose these individual problems. To us in the field, the patient has a head injury. But again, knowledge just makes us better practitioners. So knowing where the injury is occurring just makes us better clinicians. But again, this patient, regardless of the subdural, epidural, or intracerebral hematoma, has a head injury, and they're all going to be treated the same. So when we have a brain injury and there's bleeding in the brain or the brain begins to swell, intracranial pressure begins to happen. So the pressure inside the skull increases. When that happens, many things are going to happen to the patient's vital functions. Their blood pressure is going to increase, and you will see their heart rate decrease. This is known as Cushing's reflex. One thing to note, what we talked about in the patient that is having shock, their heart rate increases and their blood pressure decreases. So with that in mind, if you have a trauma patient and you are suspecting a head injury, but you see a lower blood pressure and an increasing heart rate, you need to look for another injury because those vital signs are indicative of shock. So you need to be looking for a hemorrhage somewhere else in the body. Intracranial pressure increases and cerebral perfusion decreases. This causes CO2 levels in the brain to increase. This might be one of the only times you might be asked by medical control to increase the amount of your ventilations if you are bag valve masking the patient. So this increasing pressure causes the brain to push down on the brainstem, and as we remember in our A and P, the brainstem controls our vital functions. So if we're getting pressure pushed down in the brainstem, we might have possible loss of these vital functions. For example, a patient that has a head injury very possibly could be apneic, and this is caused by that pressure being pushed down in the brainstem, causing that loss of function to their respiratory control. Another alteration you might see in your patient's breathing that is suffering a head injury is Cheyne-Stokes breathing. This is a period of breathing where the respirations increase, deepen, and then become apneic. So let's talk about our patient assessment for our head injury patient. Physically, we want to be looking at the head for any kind of depressions, deformity, bleeding. We want to note if the skull is open, that we have an open skull injury, and we want to note if there's a presence of any brain matter. We want to pay close attention to their mental status, and we want to perform the Glasgow Coma Scale, which we will cover in a few more slides. Again, check for wounds in the head, depressions or deformity. You also want to look for two indications of a skull fracture. Battle sign, which is the bruising behind the ear, and raccoon eyes, which is bruising around the eyes. We also want to take note to make sure that there is no fluid leaking from the nose or the ears. We want to take note of their pupils, their size, their reactivity, and to see if they are equal. When somebody has a head injury, it is very possible that they can have unequal pupils. We want to note any personality changes. Patients that can be calm 1 minute and agitated the next, that also can be indicative of a head injury. We want to look for that Cushing's reflex, that increased BP, and that decreasing pulse. We also want to look for posturing, and we'll cover that in the next slide. So posturing is when your patient is exhibiting stiffening of the body and extremities. It is noted one of two ways. The picture on the left, our patient is having decorticate posturing. This one's easy to remember because all the flexion of the extremities is moving towards the core of the body. Decorticate posturing. The picture on the left indicates decelerate posturing, and if you can note, her extremities are posturing away from the core of her body. Decelerate posturing. We talked about the Glasgow Coma Scale. This is a tool that evaluates 3 separate responses from your patient. On any trauma patient, you will have to evaluate this score, relay that score to online medical control, and also document that in your patient care report. So let's look at eye opening. If our eyes are open when you arrive at the site of the patient, that is spontaneously. They get a 4. If they open their eyes to your voice, that's a 3. If they open their eyes to pain, that's a 2. And if they do not open their eyes, that is a 1. That's verbal response. If they are oriented to time, place, and person, they get a 5. If they are confused, they get a 4. If they are using inappropriate words, they get a 3. Incomprehensible sounds, they get a 2. And no response scores them at a 1. For best motor response, if they are obeying your commands, they get a 6. If they move to inflicted pain, they get a 5. If they flex or withdraw from the pain, they get a 4. If they have decorticate posturing, they get a 3. If they have decelerate posturing, they get a 2. No response gets them a 1. We add all 3 of these criteria together to come up with our Glasgow Coma score. The best score is a 15. The worst score is a 3. So what is our patient care going to be for our head injury patient? Any injury to the head should be suspected that the patient has a C-spine injury. So full C-spine immobilization with a C-collar, longboard, should be considered for every patient. We want to pay particular attention to their ABCs. We want to control any bleeding, dress any wounds accordingly, manage the patient for shock, watch for vomiting, and monitor the patient's vital signs every 5 minutes. Okay, let's switch gears to spinal injuries. Spinal injuries have multiple different possibilities as far as mechanism of injury is concerned. We have falls, motor vehicle accidents, gunshot wounds, diving injuries, ATV, motorcycles, bicycles, and sporting injuries. One thing to note is that any penetrating trauma to the head, neck, or torso should be considered a possible spinal injury. When a bullet enters the body in any of these regions, it is unclear where that bullet is going to wind up. Because our brain and spinal cord runs down the midline of our body, it is very possible that the bullet can wind up injuring the spine. So when we look at our patient as far as assessment is concerned, we want to check for paralysis in the extremities, any changes in neural function, any pain with movement, any tenderness along the spine, impaired breathing, priapism, loss of bladder or bowels, any deformity, and signs of neurogenic shock. Anyone with a suspected spinal injury needs to have all their extremities checked for proper pulses, motor, and sensory to make sure that their central nervous system is intact. Spinalization is going to be our patient care for anyone that has a suspected spinal injury. The equipment that we will need is a cervical collar, a long board. If our patient is going to be a seated patient, such as somebody that's being removed from an automobile, or someone that is sitting up against a wall when we arrive, we are going to use a CAD device. A CAD device, we will explain in the next couple of slides, is a device that we immobilize the spine of a seated patient, transferring them then to a long board. Once the patient is on a long board, we need to have a head bed, and we also need to have securing straps. Some backboards come with securing straps already fastened to them. The best set of securing straps we have are known as spider straps, and we will cover this in one of our skills sessions. Shown here on the left is our long board. Here on the right is our C collar. When we apply a cervical collar, it has to be properly measured and secured to the patient so it can be used to secure the patient's neck in the proper position. We will cover this skill in one of our skill sessions. You will also note the skill in one of the following YouTube videos that you will have to view. In this slide, the image on your left is known as the KED, Kendrick Extrication Device. It is a half backboard with the securing straps already integrated into the device. It comes with 2 chin straps and some padding to fill in the void behind the patient's head and the device. This is typically used when we are removing a patient from a seated position, such as an automobile. The image on your left is a short backboard. Used with straps, the chin securing devices, and the padding, it can accomplish the same technique as the CAD device. So In summary, the image on your left is the new way to immobilize somebody with a half backboard. The image on your right is the old school way of immobilize somebody on a half backboard. Both of these are acceptable techniques to be used for a seated patient. Okay, let's move to our case study and our assignments for this presentation. Looking at the image on the slide, we see a patient that was riding a bike and struck by an automobile. Our patient is a 25-year-old male. When you arrive, he is laying on the ground. He is conscious and alert, but keeps asking you what happened. On quick physical exam, you note that he has an abrasion to his forehead, and he tells you he was not wearing a bike helmet. Upon physical assessment, again we note he is alert but keeps asking what happened. He complains of a slight headache. His blood pressure is 120/70, heart rate 92, respiratory rate 18, and his pulse ox is 98%. His lungs are clear, skin is normal, pupils equal. He has no history, no medications, and has no allergies. And again, he was not wearing his helmet. On physical exam, you note an abrasion to his forehead. No other injury on physical exam is noted. He has good distal pulses, sensation, and movement to all extremities. So here's our assignments. Assignment 1, we would like to know what your impression of the patient was and what your treatment is going to be for this patient. So we're going to cover the following 5 questions. Number 1, what steps are you taking during the primary assessment? Number 2, looking at the bike and car during your seat size up, is there anything that concerns you? Number 3, what is going to be your full course of treatment? Number 4, where are you going to transport your patient to? And number 5, what is your field diagnosis for this patient? The second assignment will be a full completed PCR on this patient. And we would also like you to view the following YouTube videos on spinal mobilization for the supine patient and for the seated patient. Thanks for your attention, and please contact Lisa or Kevin if you have any questions about any of the material in this presentation.